Hey everyone, welcome back to the channel. In today's video, we are diving into the fascinating world of diuretics, also known as water pills, and uncovering the science behind how they work to keep our body fluids in check. So, what exactly are the diuretics? By definition, diuretics are the drugs that increases the rate of urine flow, but that's not all. Clinically useful diuretics go step further by boosting the excretion of sodium ions and chloride ions too. And this process is called natriuresis. Why is this important? Well, sodium chloride is an main regulator of an extracellular fluid volume. So, when we reduce the sodium chloride in the body, we help control the fluid levels, making diuretics essential in treating the conditions like hypertension, heart failure, and pulmonary edema. But here is the cool part. Maintaining a balance between the sodium intake and the loss is absolutely crucial. Too much sodium, you risk fluid overload and edema. Too little, you could face a volume depletion and a cardiovascular collapse. And here is something even more fascinating. Over time, the body starts to fight back against the diuretics through the phenomena called diuretic braking. This is when your kidneys adapt by decreasing the sodium loss thanks to the several smart mechanisms like sympathetic nervous system activation, renin-angiotensin-aldosterone system, reduced blood pressure, and even changes in the kidney cell behavior. Now let's talk classification. Diuretics are grouped in many ways by where they work in the kidney, how effective they are, and even their chemical structure. You got loop diuretics, thiazide diuretics, potassium sparing diuretics, and more, each with the unique but a shared goal, that is to flush the excess fluid and manage the electrolytes. So next time you hear the diuretic, remember it is not just about peeing more, it is a smart scientifically designed tool for keeping our fluid balance in harmony. Now let's see each category in detail, starting with the carbonic anhydrase inhibitors, their mechanism, uses, and side effects. If you are looking for a deep yet clear understanding of how carbonic anhydrase inhibitors work, you are in the right place. From treating the glaucoma to the managing the high altitude sickness, acetazolamide is more than just a diuretic. Let's explore its mechanism of action, clinical applications, and side effects with a real pharmacological depth. Now, first of all, let's see what drugs are included in the carbonic anhydrase inhibitors. First one is acetazolamide, methazolamide, dorzolamide, and brinzolamide. And star of this class is acetazolamide. Whether it's reducing the intraocular pressure in glaucoma or preventing the altitude sickness, acetazolamide does more than just make you pee. It shifts your body acid-base balance in the powerful way. So let's break down exactly how it works, where it works, and why it is not your typical water pill. Let's see introduction and origin of acetazolamide. Did you know that discovery of acetazolamide began with the side effects of an antibiotics? When sulfanilamide was first used as a chemotherapeutic agent, doctor noticed a metabolic acidosis as a side effect. This observation led to discovery that sulfanilamide inhibits carbonic anhydrase, a crucial enzyme in acid-base balance. From there, a whole class of drugs were born. Carbonic anhydrase inhibitors with the acetazolamide, a most well-studied member. Now let's see what is carbonic anhydrase and how does it work. Carbonic anhydrase is a zinc-based metalloenzyme present in many tissues, but specifically rich in the proximal tubule of epithelial cells of the kidney. There are two main forms, type 4 on the luminal and basolateral membranes of the kidney, and type 2 in the cytoplasm. This enzyme rapidly converts carbon dioxide and water into carbonic acid, which dissociates into hydrogen ion and bicarbonate, facilitating the bicarbonate reabsorption and acid secretion. Let's see sodium bicarbonate reabsorption and acid secretion. Normally, in the tubular lumen, sodium ions are present in high concentration. Sodium enters the proximal tubule cell via a co-transporter with an bicarbonate and an counter transport with an hydrogen ions. These hydrogen ions combine with the bicarbonate in the lumen, forming the carbonic acid. Carbonic anhydrase, or the Ca, catalyzes the breakdown of carbonic acid into water and carbon dioxide. This diffuses into the tubule cell, where carbonic anhydrase reconverts into the carbonic acid and subsequently back into the hydrogen and bicarbonate ion. The hydrogen ions is recycled back into the lumen, while the bicarbonate is reabsorbed into the bloodstream, maintaining the acid-base balance. When carbonic anhydrase inhibitors are introduced, this enzyme activity is blocked. This prevents the formation and reabsorption of a bicarbonate, resulting in the increased urine excretion of the sodium bicarbonate and water. Consequently, this leads to the loss of sodium bicarbonate in the urine, causing the metabolic acidosis and hyperkalemia. The body compensates by increasing the sodium delivery to the collecting duct, where sodium reabsorption via epithelial sodium channel is coupled with an increased potassium excretion, contributing further to the potassium loss. Clinically, around 66% of the filtered sodium and 85% of the filtered bicarbonate is reabsorbed in the proximal tubule under normal conditions. With the carbonic anhydrase, with carbonic anhydrase inhibitors, this reabsorption is impaired. Notably, tolerance to the carbonic anhydrase inhibitors develops after just 2 to 3 days after use, reducing their long-term diuretic effectiveness.
Now let's see pharmacokinetics and pharmacodynamics of carbonic anhydrase inhibitors. Among orally available carbonic anhydrase inhibitors, acetazolamide has T-half of 6 to 9 hours, which means the time it taken for the concentration of a drug or any substance in the body to decrease by 50%. Methazolamide has the T-half of nearly 14 hours. All these drugs share a common sulfonamide group critical for the activity. Acetazolamide is renally excreted, while methazolamide is mostly metabolized by the liver. Coming to the therapeutic uses, acetazolamide has a broad range of clinical applications. Let's break it down. First application is for high altitude illness and mountain sickness, used prophylactically to prevent the symptoms by inducing the metabolic acidosis, enhancing the respiratory drive. And the second application clinically is familial periodic paralysis, useful in treating the rare ion channel disorder. Mechanism is unclear but believed to be due to the metabolic acidosis. And the next clinical applications of this carbonic anhydrase inhibitors is in glaucoma. Topical agents like endorsoloamide and brinzolamide inhibit the aqueous humor formation, thereby lowering the intraocular pressure, thereby treating the symptoms of glaucoma. And these carbonic anhydrase also got an neurological uses in cases like idiopathic intracranial hypertension, epilepsy due to CNS acidification, sleep apnea and dural ectasia in Marfan syndrome, and off-label it is used to correct the metabolic alkalosis, especially that caused by the diuretic-induced hydrogen excretion. Now let's see adverse effects and toxicity. Despite its utility, acetazolamide is not without risks. Common side effects include paresthesias, drowsiness, metabolic acidosis, renal stone formation, which is due to the alkaline urine, and this is contraindicated in hepatic cirrhosis, due to the risk of ammonia accumulation, hyperchloremic acidosis, and severe COPD persons due to the respiratory acidosis. And the other contraindication is the patient who has the sulfur allergy, which means being a sulfonamide, it causes the skin reactions, bone marrow suppression, and renal lesions in hypertensive individuals. Now let's see the limitations and the self-limiting effects of these carbonic anhydrase inhibitors. Over time, the effectiveness of the acetazolamide decreases due to development of tolerance, metabolic acidosis, which reduces the bicarbonate filtration, compensatory reabsorption at distal site, and tubular adaptation, reducing the drug sensitivity. The bonus fact here is in rabbits, acidosis increases Ki, which is inhibition constant. It refers to the concentration of an inhibitor required to reduce the activity of an enzyme by 50%. In ideal condition, it reflects how potently a drug can inhibit an enzyme. The lower the inhibition constant, the stronger the inhibition, which is more effective at the lower doses. And coming to the higher the inhibition constant, weaker the inhibitor. In the context of this carbonic anhydrase inhibitor, the inhibition constant of acetazolamide for carbonic anhydrase is very low, which means it is highly potent inhibitor. The passage also mentioned that in acidosis, the inhibition constant increases 100-fold, meaning the enzyme becomes less sensitive to the inhibition. More drug is needed to achieve the same effect. This likely explains the self-limiting nature of these drugs. Now let's see the clinical tips of the carbonic anhydrase inhibitors. While not a powerful diuretic, acetazolamide has a niche yet life-saving roles in glaucoma, high-altitude illness, and neurological disorders. Always monitor acid-base status, potassium levels, and be caution in the patients with an hepatic, respiratory, or renal compromise. Now let's see another classification of drugs under the diuretics is Loop Diuretics. From furosemide to ethacranic acid, discover how these drugs fight edema, regulate the electrolytes, and impact the renal function. Don't forget to hit a like and subscribe. Before we dive into this diuretics, let's understand two key kidney processes. One is reabsorption and the second one is secretion, which are crucial for how these drugs work. Reabsorption is the process where the kidneys reclaim the valuable substances like water, glucose, and electrolytes.
from the filtrate in the nephron and return them to the bloodstream. It is how your body holds on to what it needs. And coming to the next one, that is the secretion. On the other hand, it is a movement of an waste products, toxins or excess ions from the blood into nephron tubules, so they can be eliminated in the urine. Together, reabsorption and secretion controls what stays in the body and what get flushed out. And this is exactly where diuretics act. By altering these processes, they increases the urine output and help manage the conditions like hypertension, heart failure, and edema. Now that you understand the basics, let's explore how each class of diuretics targets different parts of the nephron to enhance the fluid and salt excretion. Now let's see what are the drugs that comes under the loop diuretic. One is furosemide, bumetanide, torsemide, ethacranic acid. These are the most potent diuretics available. They are also known as high ceiling diuretic because they can inhibit the reabsorption of up to 20% to 25% of the filtered sodium load. The loop diuretics acts in the medullary and cortical portions of the thick ascending limb of loops of Henle. Sodium and chloride transporter through the sodium, potassium and 2-chloride carrier in the luminar membrane is inhibited. Reabsorption of calcium and magnesium is reduced, secondary to the reduction in the sodium chloride transport. The loop diuretics also possess a vasodilatory effect that can contribute to their diuretic activity. They reduces the preload and congestive symptoms, restoring the euvolemia or dry weight. However, they don't improve survival and should be titrated to the lowest effective dose to avoid the overdiuresis, which can cause hypotension or renal impairments. Now let's see the pharmacokinetics and the action of then loop diuretics in detail. Loop diuretics gain access to the tubular lumen through the secretion of then proximal tubule via organic anion transporter. They abolish the corticomedullary osmotic gradient and affect the both positive and the negative free water clearance. Their impact on the sodium handling causes increased delivery of an sodium to the distal tubule, where it is exchanged for the potassium and hydrogen ions, leading to the hypokalemia and alkalosis. While they causes the hypokalemia, it is generally less severe than the thiazide diuretics. Loop diuretics are weak carbonic anhydrase inhibitor, except for the ethacranic acid, which doesn't improve the or increase the bicarbonate excretion. Now let's see hemodynamics and special effects. They also modify intrarenal hemodynamics, reducing the sodium ions and water reabsorption in the proximal tubule, mainly via prostaglandin release. NSAIDs can attenuate their effects by blocking the prostaglandin synthesis. Importantly, glomerular filtration rate, that is GFR, is preserved, making the loop diuretic the first line choice in a moderate to severe renal failure. Now let's see the individual drug highlights. First one is furosemide, also branded as an Lasix. The oral dose is 20 to 40 mg daily or twice daily. Maximum dose per day is 600 mg. It's known for its rapid action and vasodilation, which helps in the left ventricular failure and pulmonary edema treatment. The caution is sulfur drugs. These are the sulfur drugs and light sensitive injections, so store at a room temperature. Coming to the next drug that is under this classification of loop diuretics is bumetanide. The oral dose is 0.5 to 1 mg once daily or twice daily. Maximum dose is 10 mg per day. Most potent loop diuretic with few adverse effects than the furosemide. IV to per oral ratio is 1:1. This means the IV dose is equivalent to the oral dose in terms of bioavailability and the effect. Why this is important? This concept helps doctors and the pharmacist to switch safely between the oral and the IV routes without the dose adjustment, simplify the treatments for the patients transitioning from the hospital to the home, and avoid under or overdosing during the route changes. The other examples is levofloxacin or linezolid. These antibiotics have IV to per oral ratio 1:1. If you give 500 mg of IV, you can also give 500 mg orally with equal effect. In note here is not all drugs have 1:1 equivalency. Many oral drugs undergo first pass metabolism or have a poor absorption, so their oral dose is higher than the IV dose. Coming to the next drug, that is torsemide. The oral dose is 10 to 20 mg daily. The maximum daily dose is 200 mg per day. It has the longest half-life, ideal for once daily dosing. Coming to the next drug, that is ethacranic acid. Oral dose is 50 to 200 mg per day, which can be divided, and the maximum to 400 mg per day. Ethacranic acid does not contain the sulfonamide group, safe in the sulfo-allergic patients.
though it has the highest risk of ototoxicity. Now, let's see dose conversion for the clinical practice. Standard oral dose equivalents are 40 milligrams of furosemide equal to 20 milligram of torsemide, where 20 milligram of torsemide is equal to bumetanide of 1 milligram, and which is equivalent to ethacranic acid of 50 milligram. IV and per oral ratio for the furosemide is 1:2. Coming to the bumetanide and the ethacranic acid, IV to oral ratio is 1:1. Hope you understand this concept. If you are having any doubts, please comment below. Now let's see safety, side effects, or monitoring. The box warning with this loop diuretics is they can cause the profound diuresis resulting in the fluid and the electrolyte depletion. The contraindications include anuria, which means extremely low or absent urine output, specifically less than 100 ml of urine per day. Usually, urine output in a healthy individual is 800 to 2000 milliliters per day depending upon the fluid intake. This includes self-allergy, which does not apply to the ethacranic acid as discussed before. Side effects includes decrease in the electrolytes like potassium, magnesium, sodium, chlorine, and calcium, different than the thiazides, which increases the excretion of an calcium ions. The loop diuretic may also cause increase in the electrolytes like bicarbonate, which may be leading to the metabolic alkalosis and increase in the blood glucose, triglycerides, and total cholesterol. Other side effects with this loop diuretics is ototoxicity, including the hearing loss, tinnitus, and vertigo, which may be more with the ethacranic acid or rapid IV administration. And they may also cause orthostatic hypertension, photosensitivity, and myalgias. Coming to the monitoring part, renal function like fluid status, input or output, weight, or blood pressure, electrolytes, audiology testing with a high doses of or rapid IV administration also should be monitored for the signs and symptoms of heart failure. The main and important notes for this diuretics is they should be taken early in the morning to avoid the nocturia, which means waking up during the night one or more times to urinate. In simple terms, if you go often get up at the night to pee, you may be experiencing the nocturia, and it's worth mentioning to the doctor if it affects your sleep or daily life. So to wrap it up, loop diuretics are essential tools in managing the fluid overload, especially in the heart failure and kidney disease, but they require the careful dosing and monitoring. If you found this video helpful, smash that like button, subscribe for more pharmacological deep dive, and drop your questions in the comments. Now let's see other class of drugs under these diuretics are thiazide type diuretics. Thiazide type diuretics are inexpensive, effective, and have a mild side effects in most patients. They are one of the 4 preferred drug classes that can be considered for initial hypertension treatment. Loop diuretics are primarily used in heart failure conditions. Drugs in this group include bendroflumetazide, chlorthalidone, hydrochlorothiazide, methichlorothiazide, polythiazide, trichlormetazide, hydroflumetazide, chlorthalidone, metalazone, and indapamide. Here, chlorthalidone, indapamide, metalazone are thiazide-like diuretics, whereas other agents in these groups are thiazides. These drugs act by inhibiting sodium chloride symporter at the luminal membrane of early distal convoluted tubules, and this part of the distal convoluted tubule is impermeable to the water and absorbs only solutes. By increasing the excretion of the solutes, thiazides make the urine concentrated. These drugs reach the lumen of the nephron by secretion through an organic acid transporter system. Additionally, carbonic anhydrase inhibitory action is also exhibited by the thiazides. Decreased absorption of the sodium ions results in its greater delivery to the late distal tubule and collecting duct that is responsible for hypokalemia, and that is more than the loop diuretics. Among these drugs, chlorthalidone has a minimum potency and efficacy, whereas other drugs differ only in the potency, but the efficacy is the similar. Thiazides are moderate efficacy diuretics with a low ceiling effect. These drugs tend to reduce the glomerular filtration, therefore they are not indicated in the renal failure patients. Now let's discuss each drug in detail, starting with the chlorthalidone, which is given in the 12.5 to 25 milligram daily. Maximum dose is 100 milligram daily, but doses greater than 25 milligram per day has a limited clinical benefit. Coming to the next drug, that is hydrochlorothiazide.
It is available in the tablets and the capsule forms in the market. And the dosage is 12.5 to 50 milligram per day. Maximum dose is 100 milligram per day. But doses greater than the 50 milligram per day have the limited clinical benefit and increase the risk of adverse effects. And the next drug is chlorthalidone, which is available in the tablet, oral suspension, and injection forms. The dose is 500 to 200 milligram daily in 1 to 2 divided doses. Coming to the next one is indapamide, which is available in the tablets, and its dosing is 1.25 to 5 milligram per day. Coming to the next drug in this class is metalazone, which is 2.5 to 5 milligram daily. Now let's explore the safety, side effects, and monitoring of these thiazide diuretics. These drugs are contraindicated in the patient with hypersensitive to the sulfonamide derived drugs. And the warnings include severe renal disease, which can precipitate the azotemia, progressive liver disease, fluid and electrolyte changes can precipitate the hepatic coma, and can precipitate or exacerbate the conditions such as systemic lupus erythematosus, SLE, gout, and diabetes, transient myopia, or acute angle closure glaucoma, mainly with hydrochlorothiazides. Side effects include there is a decrease in the electrolytes like potassium, magnesium, sodium, and there will be increase in the electrolytes like calcium and increase in the other lab parameters like uric acid, LDL, blood glucose, and triglycerides. They may cause the photosensitivity, impotence, dizziness, and rash. Patients who are on the thiazide diuretic should be regularly monitored for electrolytes, renal function, blood pressure, fluid status, input and output. Is there any weight gain? Blood glucose in diabetes patients. And the main points for these thiazide diuretics are they are not effective when the creatinine clearance is less than 30 ml per minute, except for the metalazone, which may work with the reduced renal function or diuretic resistance. As discussed earlier, these diuretic also cause nocturia, so ideal to take early in the day. Chlorthalidone is the only medication in this class available intravenously. Chlorthalidone may be preferred over the hydrochlorothiazide due to the long duration if the patient is doing well on the hydrochlorothiazide, so no need to switch. Hypokalemia can be avoided with the regular intake of potassium-rich foods or potassium supplements. Coming to the drug interactions, all hypertensives can enhance the blood pressure lowering effects of other drugs. Carefully monitor the blood pressure when using combination of medications. The drugs that can cause the sodium and water retention, like NSAIDs, can decrease as the effectiveness of antihypertensive medications, so do not use in combination. And also, thiazide diuretic can decrease the lithium renal clearance and increases the risk of lithium toxicity. So do not use in combination if possible. And also the thiazide diuretics can the serum concentrations of dofetilide. Dofetilide is an class 3 antiarrhythmic medications primarily used to treat the atrial fibrillation and atrial flutter. This increased dofetilide serum concentration leading to an increased risk of QT prolongation. So do not use in combination. So to wrap it up, thiazide diuretics include the drugs like benroflumetazide, chlorthalidone, indapamide, and metalazone, acting by inhibiting the sodium chlorine symporters in the early distal tubule. This results in the increased solute excretion and concentrated urine, but also leads to the potassium loss and hypokalemia. They are moderate efficacy diuretics with a low ceiling effect and are primarily used as a first-line antihypertensives and to manage the mild to moderate heart failure. Some like metalazone remains effective in the severe renal failure, while others like indapamide also have the vasodilatory properties. The common side effects include electrolyte disturbances and higher incidence of erectile dysfunction. Now let's cover potassium-sparing diuretics. Types, mechanism of action, clinical uses, side effects, and key monitoring parameters. Now, let's see first of all the mechanism of action. Potassium-sparing diuretics acts on the late distal tubule and collecting ducts of the nephron. Here, sodium is reabsorbed via epithelial sodium channels, leading to a lumen-negative potential, which promotes the excretion of potassium and hydrogen ions. In simple terms, inside your kidneys, tubules filter and adjust your urine. The lumen is the inside space of the tubes where the filtered fluid flows. As a positive charge, sodium ions get reabsorbed from the lumen into the blood, more positive charges leave in the lumen. This make the inside of the lumen more negatively charged compared to the surrounding cells. This is called lumen negative potential, meaning inside of the tubule there is a more negative than the outside. These negative charges pulls positive ions like potassium, hydrogen into the lumen, pushing them out of your body in urine. So why this matter? The drugs that block the sodium reabsorption reduces this negative charge, so less potassium is lost, helping your body hold on to potassium. That is why those are named as an potassium sparing diuretics. These diuretic preserve potassium by blocking the epithelial sodium channels directly. The drugs like amiloride and triamcinolone, or antagonizing the aldosterone receptor, that is spironolactone and eplerenone. Aldosterone normally stimulates the sodium reabsorption and potassium secretion. These drugs interrupt this balance, resulting in the mild diuretic effects with potassium retention. Now let's see types of the potassium sparing diuretics. First one is then epithelial sodium channel inhibitor, which includes the two drugs amiloride and triamcinolone. Amiloride is more potent, long-acting, reduces the magnesium and calcium secretion, increases the urate excretion, used in lithium-induced diabetes insipidus and inhaled for cystic fibrosis. Coming to the triamcinolone, this is less favored due to the photosensitivity, poor absorption, renal stone formation, and the risk of folate antagonism, leading to the megaloblastic anemia in liver diseases. Coming to the other a class of drugs under the potassium sparing diuretics are aldosterone antagonist. Examples are spironolactone and eplerenone. Spironolactone is a non-selective, also block the androgen receptor, so used in the hirsutism and PCOS. This spironolactone is metabolized in the liver to canerenone, which prolongs the action but delay the onset. And the other drug under this aldosterone antagonist category is eplerenone. This is selective aldosterone blocker. Does not cause endocrine side effects like gynecomastia, and this is metabolized via CYP3A4, increasing the potential for drug interactions. Now let's see step by step cellular mechanism of aldosterone, what it does. Aldosterone enter into the cell, being the lipophilic steroid hormone. Aldosterone easily diffuses across the cell membranes of the principal cells. Inside the cytoplasm, aldosterone bind to the mineralocorticoid receptors. This aldosterone and mineralocorticoid form a complex which translocate to the nucleus. The complex bind to the specific DNA sequences, hormone response elements in the nucleus. These activate the transcription of specific genes, producing the messenger RNA, that is mRNA. mRNA travels to the ribosomes where it is translated into proteins. These proteins include epithelial sodium channels inserted into the apical luminal membrane. Coming to the second protein is sodium potassium ATPase pumps, which increases in the number, thereby activity or the basolateral side. So the functional outcomes are more sodium reabsorption from the lumen into the blood, more potassium and hydrogen excretion into urine, more water retention, raising the blood volume and the pressure. So how aldosterone antagonist works? Like spironolactone and eplerenone. These drugs enter into the principal cell just like an aldosterone, but instead of activating the mineralocorticoid complex, they block the aldosterone from binding. These prevent the aldosterone mineralocorticoid receptor complex from forming. And without the activation of mineralocorticoid receptor, mRNA synthesis of sodium channels, epithelial sodium channels, and sodium potassium pump is reduced. So fewer sodium channels and the pumps are made. So the net result is less sodium reabsorption, less potassium and hydrogen excretion, mild diuresis, and spares the potassium, preventing the hypokalemia. Clinical note here is aldosterone antagonists only work when the aldosterone is present. Example, in cirrhosis, in CHF, and hyperaldosteronism, they are ineffective in the Addison's disease where aldosterone is absent. Actions. Now let's see the dosing of these drugs. First one is spironolactone, which is given in 25 to 100 milligram daily in 1 to 2 divided doses. And triamcinolone is given 100 to 300 milligram daily in 1 to 2 divided doses. And coming to the amiloride, that is 5 to 10 milligram daily, and the eplerenone is given 50 milligram in 1 or 2 divided doses. So these drugs are contraindicated in hyperkalemia, severe renal impairment, Addison's disease, especially for the spironolactone, and with the strong CYP3A4 inhibitors for eplerenone, examples ketoconazole and ritonavir. Monitoring parameters include blood pressure, serum potassium, renal function, EGFR, and a creatine clearance of fluid and electrolyte loss. Boxed warnings include amiloride and trimetrin are risk of life-threatening hyperkalemia, especially in elderly, diabetic, or renally impaired patients. So it should be monitored for those parameters. Coming to the side effects, all agents causes the hyperkalemia, increase in serum creatinine, dizziness, and rare metabolic acidosis. Spironolactone is known to be causing a gynecomastia, breast tenderness, impotence, and menstrual irregularities. When coming to the trimetrin, it may causes nephrolithiasis, megaloblastic anemia, and hypersensitivity. And coming to the eplerenone, it causes the elevated triglycerides. And the amiloride, it may causes GI distress used in the lithium toxicity and cardiac failure as an inhaled form. The major drug interactions include the risk of hyperkalemia given with the AC inhibitors, ARBs, NSAIDs, potassium supplements, or other potassium sparing agents. And also they decreases the lithium clearance, increasing the lithium toxicity. For eplerenone, avoid with the strong CYP3A4 inhibitors like ketoconazole and ritonavir. And the clinical uses are heart failure because they reduces the mortality, especially the spironolactone, and resistant hypertension as an add-on to the thiazide diuretics, and it can be used in the cirrhotic edema and ascites because spironolactone is the diuretic of choice, and hyperaldosteronism, diagnostic and therapeutic use, and for hirsutism and PCOS, spironolactone due to anti-androgen effect, and lithium-induced nephrogenic diabetes inhibitors with the amiloride. In summary, potassium-sparing diuretics are weak alone but powerful in combination therapy. They help conserve potassium, block aldosterone, and reduces the hormone-related side effects. Used wisely, they can significantly improve the patient outcome in the heart failure, liver disease, hypertension, and more. So don't forget to like, comment, and subscribe for more high-yield medical content. Thanks for watching. Now let's explore the final category of diuretic agents, osmotic and hyperosmotic diuretics, a class of agents crucial in the emergency medicine, neurology, ophthalmology, and nephrology. Let's start with the basics. Mannitol, glycerol, isosorbide, and urea are the classic osmotic diuretic. Unlike the traditional diuretic, they don't block ion channels or the receptors. Instead, they increases the osmotic pressure, pulling water out from the tissues and into the bloodstream and kidney tubules. This causes rapid diuresis, the excretion of water and electrolytes like sodium, potassium, and chloride. These agents act mainly at the loop of Henle and to some extent in the proximal convoluted tubule. Because they are inert, freely filtered, and not reabsorbed, they create the powerful osmotic gradient, preventing the water reabsorption. As we all know that water always moves from the region of low solute concentration to the region of high solute concentration. This is called an osmotics. Here is the concept in the simple terms but accurate. The water moves towards the higher solute concentration because the side has a less water relative to the solute. It is not that water seeks the salt. It moves to the balance the concentration of solute on the other side of the membrane. Imagine this, you have a semi-permeable membrane like a cell wall with the two sides. Side A is a lower solute and side B is an higher solute. It's side A, low solute means you have more water. This high solute means less water. Water will move from side A to side B until the solute concentration become more balanced. This movement is called osmosis. The osmotic gradient drives water from the low osmolarity to the high osmolarity. Water moves passively, not energy needed, through aquaporins or water channels. And the misconception here is water moves from the high concentration to the low. This is only true if we are talking about the water molecule themselves, not the solute. In biology, we usually focus on the solute concentration and not the water directly.